And then now we will talk about taking pediatric referral. Um, so as I said, there is different strategies in the hospitals. In the day, you may or may not hold the referring bleep. There is tendency for the registrars, if there is many of them, to hold the referral bleep and to deal with referrals and to triage referrals. Some of the referrals will need open access, as I said, or just assurance and guidance to the GB or advice. However, in the night, I think in the nights, there is no other way. You will hold the referral bleep. So my advice for you, even if your hospital strategy is that you are not holding the referral bleep in the day, to get some exposure, because in the night there is very likely that you will hold it. The team is less, isn't it? And likely the registrar will be busy um, in sick patients or ED. So you have to get comfortable with referrals. I think having that skill is very important, because when you discuss and taking referral, you know exactly what is the patient that needs to come straight away. You are taking referrals mostly from GBs, and or at least if it's GB trainee who are in a later stage of the training than yourself. So you are taking a referral from seniors. So it will be good practice and reflection to know what kind of referrals they are coming in, and what kind of referrals, what kind of concerns that the GB will have to refer a child to the hospital. So it is really good exposure. Document clearly who is referring, when they are referring, the child details. Use the read back double check for the name, for the date of birth, for the hospital number or NHS. Read back techniques means, if he's giving you a name, if he's giving you a date of birth, 7th of July, you have to say it exactly. Don't say or yes. Sorry to explain. It can be quite simple for many of you, but just to clarify, if anyone doesn't know what does it mean, read back. You have to read back the details. What I tend to do when I started as a junior doctor in the very first year in NHS, I struggled a little bit with, the language communication and hearing back, especially that period I worked in Wales, and you can imagine, with the accent, it was even more difficult. So I used to sit near a computer system. Whenever I received the referral, I opened the computer, I ask for the hospital ID first in order to bring the child name up to compare. While the GB saying the child name, I can read back the name from the system in front of me. And this was a good, tip that was given to me, by someone else. And it was really, really helpful, especially, for someone just started NHS placement from overseas. And to be honest, it's a good advice for everyone, even for someone for years here. If you put the details and make sure that they are on the system matching, that will be better than just, write them down immediately. If you can, sometimes you don't have access to the computer system, isn't it? Some hospitals has Performa and, a clear points exactly what you need to put on the referral. Some of the hospitals don't, but this is the things that needs to be documented and taken in the referral. The best contact number to get back to the referee, and the parent number in case if there was any delay. Obviously, we need to follow. Take the referral in SPAR form. So what is the SPAR? It is the abbreviation of situation, background, assessment, and recommendation. What is the situation? What is this child's main problem that you are referring for? Work of breathing, for example, high-grade fever, vomiting, not tolerating feed. Background, does this child have significant background we need to be aware of? Because background give us, more even lower or higher threshold to accept this child or not. If he's known to have this condition, known wheezer, for example, on inhaler, this is an example of a background you would like to know. Assessment, what is the vital signs? What is the assessment of the GB? Does this child looks well, unwell? If there is any, if it's abdo pain, if there is tenderness in the right iliac fossa. And then the recommendation, what is the recommendation from this referral, why he's referring for, does he think this child needs admission, antibiotics, surgical assessment, or so ever. The time for any medication given, sometimes the GB initiate nebulizer or inhaler or give paracetamol. So just ask about the timing, because it will help later on, whoever assess this child when he arrives, to give the next medication. Is this child need ambulance or hospital transfer? This is very, very important. Please remember that on the referral. When you are taking a referral for unwell child, his vital signs all over the place, tachycardic, febrile, ask clearly, because as I said, initially the numbers doesn't necessarily reflect how well or unwell the children are. Sometimes the heart rate can be 170 in a child who's very, angry and crying, doesn't want the pulse oximeter. So ask clearly when you have abnormal vital signs, especially, or the GBs worry about a major red flag like prolonged high-grade fever. Do you think this child is fit for a car transfer with the parent, or does this child need ambulance to go to emergency department? Because you are in a ward department, you are in a pediatric assessment unit, and it's not the right place to assess seriously unwell children. The right place is A&E, where resuscitation is. So that's why we need to ask this question clearly. Obviously, it's the responsibility of whoever referring to decide that, but we have to always, advise and double check whenever there is abnormal vital signs. Do we need to involve other specialties early? If a GB referring a child with abdo pain and referring to the right iliac fossa, there is tenderness, localized vomiting, so that's mean I need to give head up to the surgical team, or a child, another GB, for example, referring a child with query testicular torsion. So I have to know that urology department needs to be involved early. And in that case, it depends on the hospital protocols. In my own hospital protocols, the GB has to call urology as well. And this child needs to come under urology to A&E. That's our own hospital, but it depends. So just think, do we need to involve early the other specialties or not? Except if sure, as I say, by time you will get more confidence and you will apply what you learn. If not, don't worry at all, double check. And that's why it's important to take the number from the beginning of the referee, the best contact number. So if you're not sure, you will discuss and get back to them. And then after the referral is accepted, update the pediatric assessment unit team. Usually there will be a board that you need to go and write down the child expected to come in and what time the referral was taken on the board. And you need to update the ward clerk in order to to bring up the notes, to print out the stickers and to be ready for this child. All right, are we okay to continue, Salma, or or do we need to stop for anything?
No, I think we're okay to go on. I'm
to
on
continue.
Yeah.
All right. Thank you. All right, so next step is discharge summaries and TTO. Mainly, you need to write down clearly the presentation and the final diagnosis. In most of the situations, it doesn't need, deep details unless it's a complex presentation. I will give you an example. A child newly diagnosed with leukemia during this admission, for example, or a child who presented with a second fit, and there is a few investigation that has been done like EEG, MRI. So such a complexity we might need to add in the discharge summary to give, more details for the GB about the presentation. But in simple presentation, like a child with bronchiolitis stayed overnight and left the second day with assurance, you can just write a child presented with cough, increased work of breathing, diagnosed with bronchiolitis, needed some feeding support, and discharged in a good condition. So it's only 3 lines now. But any complex presentation, new diagnosis, fancy investigations like EEG, MRI, we need to, put that in the summary, in the discharge summary. Final discharge plan, if there is discharge planning on particular medications and duration, we have to put it clearly. Example for that, a child who come with the asthma exacerbation and he meant to finish 3 or 5 days of steroid. So we have to put that clearly in the discharge plan. The plan is to finish 3 or 5 days of prednisolone, so on. So does this child need follow-up with the GB? If you are discharging a child after constipation impaction and he had this impaction on the ward, so the GB will need to follow, or there is any community team needs to follow that constipation, like the bladder and bowel team, for example, in my own hospital. Regular prescription, does this child will need regular prescription that the GB needs to be aware of, like Movicol, inhalers, new type of asthma preventer, new epilepsy medication, all of that prolonged medication, make sure that it's on the discharge summary for the GB action to re-prescribe. Ask yourself, does this child needs follow-up with the assigned consultant or not? Any pending investigation to chase. If there is any investigation, they are still in progress, we have to put them in the chasing list or email the assigned consultant, so this will be not missed. An example for that, a child present with viral illness, but doctor suspected the EBV virus during the admission, and this has been sent. So we need to chase that, because if it's EBV, the parent needs to be aware. They have to have safety netting for, sport contact, against spleen rupture and all of that. So this is just an example of pending investigations. In pediatric, we do have sometimes ambulating, so kids who are still due to finish IV antibiotic course, they can have it in the community, or they can come in and out to have the injection, the antibiotic, and can go home with the cannula. It also depends on the policy in every hospital, but in mine, kids can be discharged and come back to have their antibiotic and go home with safety netting and open access to come back if they are unwell. So in that case, we need also to make sure that this is all written and documented on the handover. Take home medication, calculate the duration, exactly how much days left needed. The parents needs to be aware of the duration and the timing, because on the ward it was something facilitated by the nurses, and now the parents are on their own giving the medication at home. So make sure that they have full understanding of how many days left and the duration. And just a gentle reminder that discharge summaries are teamwork. It's not only you who meant to do discharge summaries, but on the same time, if your registrar is busy, with a sick patient, he might ask you kindly to do a discharge summary. It's not necessary that we have to see the child to do a discharge summary. And if this makes you more comfortable, some doctors write a line, the child was not seen by myself, discharge summary from the notes. If this will make you comfortable to write that line, that's fine. So it's a teamwork. If you are busy with a lot of jobs and your registrar free, then he can help with that. It's not assigned for doctor. It's not junior doctor job to do discharge summaries. Anyone responsibility is to do a discharge summary, and ideally it's whoever who saw the child, either a consultant or a registrar or a nurse practitioner or yourself. It's whoever responsibility that's seen last this child to do the discharge summaries. But it's a teamwork. Obviously we distribute jobs according, to whoever is free, and depends on the urgency of the jobs as well. So just keep that in mind, and don't be overwhelmed thinking that, oh, all of this pile of this chart summary is only mine. It's everyone's job. However, it's a teamwork. If you are free and you have the time and the capability of doing them, then please. Okay. Unwell child assessment. So in some situations, if the child, if your registrar is busy with critically unwell child in the middle of the night, there is no other way. Ideally, if a nurse is overly concerned about the child who's unwell, ideally you will go together, you and your registrar. But in some circumstances, the registrar may not be able to see the unwell child because he's busy with a critically unwell child, somebody who needs more escalation and senior attendance. So don't panic, just follow the basic steps. That's all what's required from you. Use ABCD approach assessment. What is the urgency of escalation? Is the registrar available immediately or not? If this child needs immediate escalation, there is no other way. Just press, the crash buzzer, and it is what it is. If he needs immediate escalation, example for that, a child who's getting apneic, getting desaturated despite it of 15-liter oxygen mask, there is no other way. You do need your senior. So just think, what is the urgency of this escalation? Can I see the child first, assess him A, B, C, D, E safely, or do I need immediate escalation? Is he seriously unwell and I have to get my senior? Escalate using, again, the SPAR, situation background assessment recommendation. It's a good practice to use the SPAR for everything. When you are taking referral, when you are discussing with other specialties, if your for example, consultant asks you to discuss with radiology something. If you are, for example, escalating to your registrar a child that you already seen on the ward, SPAR is a really good way to speak and to to give information and to take information. If you are taking a referral, you will also use the SPAR. So remember always in any assessment, what's the situation, what is the background, what is the outcome of this assessment and vital sign, and what do I think, the recommendation, what's going on. Senior nurse in charge can help if your registrar is busy. The nursing team is a huge help of the in the pediatric ward, and their experience is really outstanding. As a pediatric registrar, I always involve the senior nurses, take their opinion in vague presentations and what they think. So it will be really helpful, especially if your registrar is busy, to ask the senior nurse if she have a particular concern or what does she think. Follow the guidelines. Example, wheeze, croup, sepsis. So in unwell child, usually there is a clear pathway guidelines for major presentations like croup and sepsis and wheeze. You can follow them if your senior is busy safely and apply them. Priority for unwell children and handover safety, anything pending, not urgent. So what I mean by that, don't get yourself overwhelmed. Don't get yourself worried that I have plenty of non-urgent jobs, I have to finish them before the next shift. No, you don't. Your priority is for the unwell child, and then everything else can be handed over safely to the next shift. Just have that mindset of urgent is urgent, and then pending jobs can wait for the next team safely, because this is, your main job, the unwell children, to make sure that they are safe. And in medical ethics, we need to justice in medical ethics, what it is the equal and fair distribution of the resources. Equal and fair, so it's fair for a well child with something like bending TTO to wait if there is unwell child who needs immediate escalation and your attention. So remember, it is totally fine. and don't get yourself overwhelmed with non-urgent jobs if you have an urgent job. Next step, we're gonna talk about some common pediatric presentations, just a quick overview. And in agreement with Dr. Shukri, we agreed that we can do more sessions in depth for this common presentations in pediatric in the upcoming couple of weeks. But for now, I will do like a quick overview for 3 conditions that I have chosen for you today, especially that winter is coming. First of all is bronchiolitis. It's a viral presentation, obviously, of the lower airway bronchioles, and mostly is RSV virus, but there is also rhinovirus, parainfluenza, adenovirus, metapneumovirus also comes very frequent recently. The peak age of bronchiolitis is 3 to 6 months, and the most symptoms is coryza symptoms, and then followed by chest symptoms like wheeze, distress, all of the signs of the respiratory distress that you can think of, subcostal, intercostal recessions, tracheal tug. This is preceded by just a coryzal period of snuffly nose and coughing. Usually the duration is anything between 1 to 2 weeks. The first 5 days, the condition get worse and worse until it reach a peak of the 5th day. And then after that, we expect to see improvement. In your assessment, you will assess if this is mild, that the child or the baby can go home. And mostly it's a baby because it's an illness around less than 1 year of age. So you will assess if this baby can go home safely with the saturation and feed. Moderate, if he had some distress, some signs of distress, but he's still feeding well. He still feeds 50 to 75% of his norm. His saturation is still acceptable in air. He doesn't need oxygen, so this is moderate. And the severe bronchiolitis definition is when the children needs oxygen support. If there is any red flags like apnea or feeding is less than half of the norm, this is absolute criteria for admission. Management of bronchiolitis is supportive. They are not usually for antibiotics unless there is a secondary infection. You will support with oxygen. In some severe scenarios, we support also with high flow, with pressure. Like Optiflow and CPAP. Feeding support can vary between like lower the feeding to 2/3 and give less, more frequent and less amount feed by the bottle. We can also escalate to NG feeding, 2-hourly or even sometimes 1-hourly. Or if it's severe bronchiolitis, we escalate to intravenous fluids, and we prefer that the child will be null by mouth. So it depends on the severity. Suction, it depends on the policy really. Most of the hospitals and guidelines is not recommended unless there is a clear secretions and blockage that you can see affecting the child breathing, but it's not a routine thing at all and not advised routinely. Obviously, no antibiotic, steroids or bronchodilators will work in a classical bronchiolitis presentation less than 1 month of age with positive proven virus. So usually these things are off the table. Admission criteria, we have red flags if the baby is less than 6 weeks, in prematurity, in comorbidities like pre-existing heart problem, if there is severe moderate features from the above that I have mentioned. Social factors as well make a huge impact. If this is the first time mom, anxious mom, lack of support at home, all of that, give us a lower threshold to keep the child at least overnight. Complications of bronchiolitis, it can lead to respiratory failure, and the child might end up needing intubation and referral to the pediatric ICU. It can go this bad, especially with premature babies and pre-existed, risk factors. Prognosis, usually it's self-limiting and resolve 7 to 10 days, sometimes, fairly up to 2 weeks. Okay, so this is bronchiolitis. This is the condition that you really need, to learn and know about if you're going to the pediatric placement in winter because it's more commonly in winter. Croup as well, the same. Again, a viral illness of the upper airway. So it's an upper airway viral infection of the larynx and the upper trachea. It happens anything between 6 months to 6 years, but the peak is 6 months, I would say, to 2 years. Parking cough, hoarse voice, inspiratory stridor, and coryzal symptoms. And your assessment, the mild will be only parking cough. There is no stridor. Watch videos, educational videos on YouTube. It's very, very useful if you're going for the winter placement to be comfortably, assessing and knowing that this is croup, or this is wheeze, or this is grunting. So watch all of the types of respiratory distress in children and what they can, be underneath reason. Moderate stridor at rest. Sorry, 1 second. Thank you. So the moderate, they will have stridor at rest, not only with crying and when they are awake, sometimes at sleep. And severe one is a red flag that they need, the attendance of the ENT team and the anesthetist. He might need intubation. So the child will be having stridor at rest. He will have, an extension of his neck trying to catch his breath, agitated, hypoxic with oxygen requirement. So this child will need immediate ENT and anesthetic, review. And he could possibly, need intubation. Management, so with mild croup, when it's parking cough and the stridor not at rest, only when the child cry, oral dexamethasone works as magic normally. And the review on the pediatric assessment unit, we can safely send the child after half an hour or 1 hour after dexamethasone. It's really short acting and it works very quickly. And they comment clearly that the child is settled, the parking cough settled, and there is no more stridor. Moderate to severe needs nebulized adrenaline. So this is when the stridor is at rest and the child is sleeping, still having stridor or at rest. He will need nebulized adrenaline. And avoid putting the child into more distress. Try to, avoid intervention like, for example, throat swabs and multiple observations and multiple pulse oximeter. Admission criteria, obviously, severe symptoms, stridor at rest, poor response to the first set of steroids. So if any department called you and they say, we gave the first dexamethasone, the child is still having stridor at rest. So this is a criteria definitely for admission. And in some situations, the registrar might need to review downstairs in the emergency department. I'm only saying downstairs because it's downstairs in my hospital, but who knows? And then prognosis, usually it's good response for dexamethasone. There is tendency for the children with croup to have, again, the same presentation. And then complication, respiratory distress, bacterial tracheitis, and rarely intubation. So just I advise you to watch educational videos for stridor, in order to diagnose croup, and for grunting, because chest infection and severe bronchiolitis come with grunting. Grunting is expiratory sound. So the child will breathe in and then will do the sound of grunting, while croup is sucking in sound. Where the child, when he breathing in, you will hear the sucking in sound. So that's the main difference in the respiratory cycle. And the third condition is pediatric sepsis. It's very, very important to have a solid awareness of pediatric sepsis sign. Red flag group, or the groups at risk, and we have a low threshold to admit and think sepsis, is neonates, and babies less than 3 months presenting with a fever. Usually it's a fever presentation, but I'm not surprised if a child with sepsis came with cold with a temperature less than 35. It's not uncommon at all. So always think sepsis in the extremes of fever, when it's high grade fever or when it is less than 36. Red flags when the child consciousness is, altered, when they are lethargic, when they are less active, not doing anything. Obviously, cyanosis, mottled, grunting, prolonged capillary refill when you assess the circulation. Non-branching rash is a huge red flag, and reduce urine output. On the same time, when you are assessing child for a fever and we think this child could go home, we have to assess those red flags and we have to document clearly that they don't exist. And this is the safe practice that I want you all to have with your assessment. And obviously, if sepsis is confirmed, it's a golden 1 hour that we have to start immediately. Oxygen, access, bloods, sending culture, starting broad spectrum antibiotics according to the guideline, fluid bolus, and early senior involvement and escalation. What is expected from you as a GBST1? We expect from you to be effective member of the team, not to be, a doctor just for escalation. Always assess if it's safe, if the patient does not need immediate senior attendance. As I said earlier, the escalation itself, there is different urgency of escalation. So if it's safe to assess the patient and to check the guidelines and to apply your knowledge, always do that and be effective member of the team. Ask for help and apply advices as well. It's a very senior led, and no judgment for asking, especially in the first few weeks of placement. We expect you to ask and apply advices. On the same time, we would expect you to develop a safe independency. So you cannot ask about the same presentations and the same question all over the 4 months of placement. And as a registrar for 4 years in pediatric, I'm telling you now what are the things, that really will show that this is going to be a future GB that will work safely with kids, and he will only refer necessary referrals. You can tell from the way that they develop from the beginning of the placement toward the end. So always reflect. If you are assessing a child with not opening his bowel for 5 days, for example, what was the questions that your senior asked you to double check? Like if the child is passing wind, if the child, is sleeping fine, if the child, for example, have any urinary symptoms with this constipation. So those questions in the next assessment, if you have the same presentation, I would expect you to cover them and to not repeat yourself in the advices. This is really how you will develop. When you assess any presentation, reflect in and out, check the guidelines, so next time you will be more independent and to develop that safe independency toward time. To be safe in your assessment, examination, and prescription, not to miss red flag. When you document behind your senior, always document red flags. When you do the pediatric clerking, when you assess children, go through any red flag of the presentation, make sure that it doesn't exist. And we obviously expect safe prescribing to assess look at the BNF, look at the guideline, and to be a safe doctor. To be proactive, for example, check the guideline before checking with your senior. If you have a presentation of a child presented with wheeze, and if it's safe and the child is well, to check the guidelines of stretching or to check the guidelines of steroid. I would, be pleased if you become proactive and checking the guidelines first. Be proactive, update the handover list and the job list. Have resilience and flexibility. Sometimes your job designation, if you are assigned for a clinic in a busy winter, sometimes you may be asked to change it to a different day. And obviously you have to keep your right. You have to keep, your personal development and your right to attend teaching and to attend clinic on the same time, to have flexibility and to have engagement in the team when they need you to be somewhere else. And we expect you to speak early if you are struggling with anything, and to if something you cannot cope with, to speak early. Chat with a registrar that you find you are comfortable to chat with, or a consultant early if anything bothering you or you feel overwhelmed about anything. um, there is an advice that I always give to anyone who starts a new work environment. It is tricky to start in somewhere new and to learn the basic things. No matter how knowledge and how experience you have, there is always room for learning and finding new stuff. And sometimes can shake your confidence a little bit, and sometimes can make you centered of the people responses and the people answers when you ask and when you interact with them. So what I advise you in general, to choose your battles. Some of the things you can just slip away and reflect on them, and some of the things do really needs escalation and needs to have with some chat with someone else if you are uncomfortable, or if something particular bothering you about work in general, or any interaction with colleague. So just you need to be we need to be professional in our interactions, because things happen, especially in a stress winter time when it's really busy. Interactions happen. We are all human beings. So know when to just reflect and let it go, choose your battle, and when you need to escalate and speak about it. If it's really affecting you, don't keep it in your heart. Difficult parent conversation is another area that I would like to highlight. Um, Check first, is this conversation appropriate for your grade or not? Not all of the difficult parent conversations is appropriate for ST1 trainee level. Some of the conversations are really challenging and it does need a senior. So check and before you respond to the nurse, if she's worried about a parent who's unhappy about something. And I'm speaking about the complex scenarios, like for example, a parent wants to self-discharge because they are unhappy about the waiting. This is an example. Or for example, a parent is unhappy due to a delay in giving particular medication. So those conversations, I think, as an ST1, you can, give it a go if you feel confident and speak. But some of the conversations, like updating, for example, a scan with a major serious thing like a tumor, or a full blood count that's showing blast cell. So those conversations you might attend first and observe. And if you feel comfortable, that will be great to do them with a senior along you. So always choose what kind of conversation that I can do confidently as ST1 trainee, and what are the conversations that no, I need my senior help, and either me shadowing him or the senior will be with me in this conversation. Introduce yourself in any parent conversation. Listen. This is the key, really. For any difficult conversation, sympathy and empathy, appreciate the situation and the difficulties, acknowledge what's going through, and explain what you know only about the situation. Don't assume things when you discuss any difficult conversation. Don't assume things. If you know something, explain it. If not, explain that you will double check and you will come back to them with an update. This is something like for a delay in a transfer, for example, to a different hospital, or a delay in a particular test, and things like that. Apply plan if appropriate, if there is any outcome, or explain and tell them that you will get back to them. Don't give a timeline. It's very tricky because it will make even the situation worse. If you did not come without that timeline and it's really busy, it will be tricky. Just explain that you will do your best. You will double check regarding when this investigation will be done, or when this transfer will be ready, and I will get back to you. And always, obviously, document the summary of the conversation. I think we are approaching the end, if I am not wrong. Oh, teaching, sorry. Teaching a lot of to learn in the pediatric. It's better to be as the go, not to assign a particular day of teaching, but every day will be something new to learn. If you open a guideline, if you look at the pathway, this is a learning, goal that you gain. So make it always on the go. Get as much as pediatric assessment unit exposure. So the pediatric assessment unit is where you receive and see patients for the first time. Get as much exposure as you can. Even if you are on a ward round day and the ward round finish, there is no jobs, don't hide, and offer to go to the pediatric assessment unit and see one or two patients. Get yourself a mini kex or a CBD with another senior. Even if your assignment in that day in the ward and there is no jobs, nothing to do, why not go and see one or two patients with the PAU team? And it will add a lot to your learning. I think personally, pediatric assessment units is the best place for the GB trainees to see the patient for the first time from scratch. And this is what happens reality in the GB. You don't see admitted patients, isn't it? You see patients with a new presentation. So that's why get as much as pediatric assessment unit exposure as you can. Ask and discuss. Don't be shy, even in the most busy day, no matter how crumbly and busy your registrar look. Always ask and discuss. Don't be shy. This is your right to learn and to get taught. Apply what you learn and reflect on future similar presentation. I think I mentioned this 4 times now. When you see a child and you apply a plan, next time, go ahead with that plan and, develop that safe independency over time. Focus on the knowledge you need as a GB, future GB, and balance this with being a good team member. It's not all about, oh, I am a GB trainee, I'm gaining only for my GB placement. We need to be effective team member and help and get engaged in things that we might not deal with in GB land. On the same time, we have to always focus on our learning and try to get as much opportunities of learning that is available. If there is nothing on that day on the ward, ask kindly, can I go to pediatric assessment unit and see new patients? And this will be really proactive, move from you. Involve in the departmental teaching, and this include attending and presenting and getting, actively involved. Your well-being is very, very important. Pediatric placement can be really, really busy, especially in winter. Take your breaks regularly, come back to work well rested and have plenty of sleep. Hydrate, have healthy snacks. I'm not sure how healthy the snacks will be in pediatric. We have lots of chocolates and, biscuits, but I always advise, eat healthy, drink healthy. It will reflect on your energy and your well-being. Maintain the separation between home and workplace. Be professional when dealing with difficult colleagues. As I said earlier, choose your battles, speak early, and don't keep it in your heart. Reach out for help early. If you feel like you're not coping, if you are stressed, if you feel like there is particular area you need someone to help with, like cannulation, for example, or prescribing or dealing with the discharge system or taking referral. If you feel there is an area that you are less confident at, speak early and say, I think I need improvement in this. How can you help? Maintain a good character. Dress by the code, smell fresh, be, have a smile in your face, and be a helpful team of the member, always ready, be proactive, ready to help. And this is the character, that people on the same time will reach out to you and help you if you show that. Debrief and reflect. Debrief and reflect in any difficult scenario, like, for example, a child who's really unwell, presented through ED, transferred to ICU. It can be really, overwhelming and stormy, especially with children. So always reflect and think, and always think what will happen if similar presentation come to me in the media, in the GB placement. What are the things that I learned from this presentation, and reflect on the portfolio. Give priority to the urgent job. Don't overwhelm yourself. If there is a sick child that taking your time, don't worry. Safe, non-urgent job, safely hand over and finish on time. Don't stay because you have a job of list. Hand over them safely because you were working and you were attending unwell child. So don't overwhelm yourself. Have a list of useful emails, numbers, referral pathway, things that can make your move around and your work a bit easier. And I think this is the last slide from myself, if I'm not wrong. Yes. Thank you so much. I'm so sorry if it was longer than I thought. I think about 1 hour and a half.
Well, thank you so much, Selma, for that. I really appreciate it, and I think it was quite useful.